Nephro-Uro Cross Talk in solving difficult cases. The panelists are Professor Ashok Kumar Basu, respected senior professor of pediatric surgery in Institute of Child and Kolkata, Dr. Suchismita Saha, who is an assistant professor in the division of pediatric nephrology in the Institute of Child and Kolkata, and Dr. Suchismita Saha. She is a fellow in the division of pediatric nephrology in ICU. Please, hello. So I would request all the panelists to please come and take your places. Sir.
Hello, good afternoon everyone. Good afternoon. So we will be highlighting two cases to understand the necessity of regular interaction and feedback between nephrologists and urologists. So for the first case, we have a child, male child who is presently 7 months old. He was the second born child of a non-consanguineous marriage and antenatal history was uneventful. As per the history that was given by mother, there were 3 antenatal ultrasound scans done, but it did not detect any abnormality. He was a single-term born with a birth weight of 3.25 kg at 38 weeks, appropriate for gestational age, and there was no history of any NICU stay. So at 1 month of age, he presented with complaints of frequent vomiting. So an ultrasound abdomen was done primarily to rule out congenital hypertrophic pyloric stenosis. It did not detect that, but incidentally, it detected that the right kidney was 3.8 by 1.4 cm, showed raised echogenicity with lost corticomedullary differentiation, and there were multiple cysts of varied size in the right kidney, the largest being 10.8 by 10.4 mm. The left kidney was 4.8 by 1.9 cm. There was no hydronephrosis in the left side. Ureter was not commented to be dilated. Urinary bladder wall thickness was normal. So, my first question would be to both Chandukta ma'am and Basu sir, that how would we approach next and if any other investigation was needed. So, he was diagnosed with a case of right-sided multicystic dysplastic kidney most probability. So, how would we approach next and what would be the investigations required?
So having a right-sided multicystic dysplastic kidney, and the previous session also we discussed about the approach to MCDK. Have a good ultrasound can give us a lot of information. So once we get an MCDK, so that ultrasound will tell whether the other-sided kidney is having any kind of hydronephrosis or the ureters are dilated or not. As she was already mentioned, it is not there. So we will just do a follow-up for this child. Blood pressure monitoring, salt restricted diet, maybe kidney functions have to be monitored, and periodic ultrasounds 3 to 6 monthly to see the kidney sizes, if it is regressing, what is the compensatory hypertrophy of the other side. One thing I would like to mention in this respect that around 30% of the cases, children with right-sided MCPK often have a reflux on the other side, but it is mostly mild. Severe reflux is present in only 3 to 5%, so there is no point in doing a regular MCUG, routine MCUG, if the child is asymptomatic. Just to monitor the child will be good enough. And also these children may have in 3 to 5% cases may have PUJ or VUJ obstruction also. So these only follow-up can give us the idea if there is an urinary or any other complication coming up. In that case, we will further investigate the child.
I agree with that completely. The ultrasound that we need to do as to be a good ultrasound by a good urologist, so that the anatomy and the identification of the cyst and the kidney are very well defined, because we have to repeat ultrasound subsequently just to see that it is given. And yes, I agree with her, there are incidences of nephrosis and reflux on the other side. So if we have to keep looking for changes in the size of the kidney and the ureter, and also look for urinary tract infection. If there is a urinary tract infection, we may need to do some investigations also. Thank you.
Thank you, sir and ma'am. So for the index case, as advised, the mother was warned about the danger signs that she needed to be aware of, and he was asked and planned for regular follow-up. At 3 months of age, he presented with complaints of high-grade fever, and there was an associated episode of febrile convulsion. During that time, at evaluation, urine routine microscopy showed plenty of pus cells. Urine culture report did not reveal any organism, but it was treated as a first episode UTI, and he was treated with antibiotics. So again, I would like to ask the question to Dr. Chandrukta ma'am, that what antibiotic needs to be given in a child with first episode of UTI who was presently 3 months old? For how long do we give the antibiotics, and what should be the route of administration?
So, in this child, the child is 3 months old. Child had a fever following which a febrile convulsion, and then detected with UTI. So once we send the sepsis markers and routine and urine culture, we will start the child on empirical antibiotics. Preferably started IV antibiotic because the child had a convulsion. Once the child stabilizes, we can shift the child to oral antibiotics and to be continued for 7 to 8 weeks. And once we get the culture reports, we will modify the antibiotic according to the sensitivity pattern of the organism.
Thank you, ma'am. So I would now like to ask Dr. Basu sir that in this index patient, if we need to investigate it further, and how should we proceed for that?
This child has one episode of infection. This is a boy.
Yes.
Yeah. So we usually treat the infection in full, and again repeat the ultrasound to find whether there is any change in the kidney or the kidney. And in a boy, infection at 2 months, we will do an invasive test like MCUG to rule out the reflux disorder.
Thank you, sir. So a repeat ultrasound was done once the infection was treated, and the repeat ultrasound showed the persisting right-sided multicystic dysplastic kidney, but an additional finding was a left hydronephrosis with anteroposterior diameter of 14 mm. Bladder wall thickness was commented to be normal. So since the ultrasound showed an added abnormality, we proceeded with lecturating cystourethrogram, and it revealed a left-sided grade 5 viewer. The bladder shape was commented to be normal. There was no evidence of any pelvic junction obstruction. So after treating this episode of urinary tract infection, he was discharged on prophylactic antibiotic as oral cefalexin. I'll proceed to the next slide. Okay. So I would like to ask that how do we usually grade the vesiculoureteric reflux, and other than MCUG, any other investigation can accurately diagnose the reflux?
There is a grade 5 reflux.
Yes.
So we need to evaluate the kidney and the renal function before we let the patient go. And if we find it's a grade 5 reflux, it's a serious problem, and this child may need some intervention, whichever way. So, prophylactic antibiotic will start, but this child will need some intervention. What do you think?
So, at 7 months of age, with grade 5, you are given that the outlet seems to be normal, so obviously, you are. I would be loath to think of surgical therapy so soon. This is probably, it is obvious to check for scarring, and most of the time we will allow antibiotic prophylaxis to continue, and if the child makes it through without urinary infections, there is a good chance that the reflux will reduce in severity.
Thank you, sir. So, for our patient, we had research on oral prophylactic antibiotics. Danger signs were again explained and reinforced to mother, and we had planned a DMSA scan after 12 weeks. So, after this, at 5 months of age, he was readmitted with history of fever. Urinary again showed plenty of pus cells, and multistrict showed positive leukocyte enterics and nitrite. Urine culture showed growth of Klebsiella with significant colony count. He was initially started on antibiotics empirically and later shifted to antibiotic as per sensitivity and received injection meropenem for 10 days. So this was his second episode of urinary tract infection. So the problems that were faced for this child was that first, he was having a breakthrough UTI in spite of being on prophylactic antibiotics. Also, although we had planned a DMSA, it could not be done due to a recurrence of urinary tract infection within 12 weeks. So, I would like to ask the questions that we had in mind. There were 3 questions. First, since he was having a recurrent UTI and there was unilateral hydronephrosis, if there is a requirement of an EC scan to rule out a left-sided obstruction. Also, since a grade 5 viewer was present, if a diversion surgery will help to prevent the reflux injuries in the left side, since it was the only functioning, probably the only functioning kidney for this child. And in case of such a diversion surgery, what measures can be taken or what alternatives can be done in the procedure of doing a diversion so that we can ensure the proper development of the bladder.
Diversion is the last thing that is surgery to consider. This patient has a good sized bladder. This patient has a grade 5 reflux. And this patient has a good renal function as far as the information given. So I would definitely like to have a GFR estimated by whatever means. And I would not divert the patient. I would just like to, after controlling the infection, reimplant the patient, not do diversion. But yes, my indication for diversions are different. One is that in the patient who I cannot treat the infection with medication or whatever means we have, then we go for a diversion. Second is progressively deteriorating in spite of all my failures. These are only the 2 indications which will lead to a diversion. And nowadays, when we do diversion for a unilateral kidney, we want to over diversion, which will send some urine down the bladder so that the bladder remains active.
Thank you, sir.
Regarding the EC scan, from nephrologist point of view, as we have already established a grade 5 viewer, so I shall not be proceeding with an EC scan for this child. Sir, if you want to.
There is a debate about whether you can do a isotope scan when the child is in active infection.
Oh, sir, after ruling out the infection.
Yes.
After controlling the infection.
Who is having febrile UTI, there, if you want to make sure that whether the child has pyelonephritis or not, you are allowed to do a DMSA scan. And also, we should show you the isotonic areas telling you that the child has pyelonephritis. Yes, as a logical As a logical person, I will avoid doing a isotope scan in a patient who has application.
Can I just put one more? Can you go back to the earlier slide where we saw the VUR? Yeah, so in this slide, as you can see, the child definitely has great high VUR, but as you see in the final part of the MCUG, you do not see any hold up of the dye and the phase evacuation. I do not know what time that picture was taken, but that does seem to indicate that there is no hold up or obstruction. So the real requirement for an EC scan does not seem to be there. The concern regarding the diversion versus the implant is basically something that we've all grown up with, and that is traditionally it was held that below 1 year of age the bladder is very small and it is very difficult to achieve an adequate tunnel to reimplant these patients. This was the basis why we were thinking of diversion in those patients as well. Nowadays we know that people are doing viscoscopic reimplantation, and we are now seeing that the ratio of the tunnel has decreased from 5:1 to about 3:1, and everyone is very happy. There are other methods to do reimplantation in a small bladder, which is something called a nipple reimplantation, nipple valves that we create. So we don't really need to create such a long tunnel. So nowadays I think unless the bladder is really very, very small, most of us would be considering that we would do a reimplantation, a definitive surgery instead of doing a diversion.
Thank you, sir.
Very well said. And about reimplantation, what he said is absolutely correct. We do open reimplantation, we do laparoscopic reimplantation, and we also do real and we also do transvesical endoscopy reimplantation. So doing transvesical endoscopic reimplantation is rather you are cramped. So if you are cramped, you cannot make a very long tunnel. And if you are unable to make a very long tunnel, you reduce the length of the tunnel and say, that's good enough. But it's true. But the point is not how you do the reimplantation, but you make a decision, yes, this patient needs reimplantation. So if I find that the patient is having increasing amount of scar and reducing GFR, I will definitely go ahead and do a reimplantation, whichever way. Reimplantation is gold standard. They are 98% success. The rest of the laparoscopic or vesicoscopic are from 60 to 80% success. So, whichever way I go, I will reimplant it.
Thank you so much, sir. So this was the first case that we had. When the child was admitted, there were differences in opinion regarding the further management of this case. So we thought of putting it up here. So I will proceed to the next case now. So the second case, he is also a male child, presently 2 years old. He was the firstborn child of a non-consanguineous marriage, and in antenatal ultrasound scans in the second trimester, mother was diagnosed with the mother in scan, the fetus was diagnosed with bilateral mild hydronephrosis. There was no associated comment on thickening of bladder wall. There was no associated oligohydramnios either. So she was followed on regular ultrasound scans, and soon after this child was born, he was born in an NICU setting, and the child was catheterized after birth, and the postnatal ultrasound scan was done within 48 hours. It revealed persisting bilateral hydronephrosis with anteroposterior diameter of 8.5 mm in right side, 8 mm in left side, and thickened urinary bladder wall with a bladder thickness of 3.5 mm. So my first question would be to Dr. Suchismita ma'am, that in such a condition with our postnatal scan revealing bilateral hydronephrosis day 2 with thickened bladder wall, how should we proceed?
So this is a male child having bilateral hydronephrosis and thickened urinary bladder wall, very much suggestive that there is a lower urinary tract obstruction. So we have an extensive session after this on PUV. So I shall be just covering up in short. We shall first of all, after catheterization, there may be a diuretic phase. So we have to manage the fluid and electrolytes accordingly for this child and confirm that the urine is sterile. And once we do that, we have to proceed with an MCUG as early as possible. And also take the pediatric surgeon in loop at this stage. And once the MCUG confirms that there is a posterior urethral valve, then cystoscopic fulguration can be done from the pediatric surgeon side. I think sir is better to talk about it.
Thank you, ma'am. So, accordingly for this child, we proceeded with an early micturitic cystourethrogram, and if we observe the films, we can see that his urinary bladder was having an abnormal shape. It was there were multiple claviculations. There is a diverticulum. There is thickening of the bladder neck. There is significant difference in the diameter of the anterior and posterior urethra, suggestive of a probability of posterior urethral valve. My question would be now to Dr. Basu sir, that what would be the surgical management of this case? By this time we had already informed the surgical team, and also if there is a role of circumcision in this children with PUV, should we proceed with it in this setting only, in the first operation itself?
My earnest request to all the pediatricians and the nephrologists present here, please, before you do an MCU or decide to do an MCU, please take the surgeon into the loop. Because the problem is, if you do an MCU in a patient who you have already diagnosed that the patient has an outlet obstruction, and do not take care of the patient immediately, then you are likely to get into the problem of a calcitrant urinary tract obstruction, which is extremely difficult to treat, delays the treatment, and you may have permanent damage to the kidney because of this particular infection. So before you decide or do an MCU, please get the surgeon who will treat this patient ultimately into the loop. That is one. Second is, this patient, any patient who had outlet obstruction for the last 3 months or 4 months, since the child was 12 weeks in the utero, the child has obstruction. And this child is only 2 days outside the womb. So if you catheterize this child, the child is bound to go into a diuretic phase. Now you can treat the diuretic phase before an MCU or after an MCU. There is no problem. Some surgeons prefer to put in a catheter, treat the diuretic problem, do an MCU, and within 24 hours do a fulguration procedure. There will be others who will say, no, we will not put in a catheter here. We will do an MCU on the table, do a fulguration, put in a catheter, and treat the diuretic problem in the post-operative period. But that problem needs to be treated. In the 80s and the early 90s, we used to have a lot of death in neonatal posterior valve cases. And that is only because we did not have the realization that these patients go into diuretic phase, and unless we treat the diuretic phase properly, we are going to lose this patient. So there are two problems. One is that if we are indiscreet, we may put in infection which will be difficult to control. And second is that these patients who have a diuretic problem, perioperative, which we need to address to for getting a good result.
Thank you, sir.
Yes, that is another very important question. Role of circumcision. This patient need to be circumcised because the literature says that the incidence of urinary tract infection in a patient of posterior not circumcised is higher. But we usually do it during the check cystoscopy after 2 months when we circumcise the patient.
Thank you, sir. So for our patient, unfortunately during his hospital stay in the first few days after the MCOG, his sepsis screen was positive. He had to be treated with IV antibiotics for a few days and cystoscopic valve fulguration was done at 16 days of life. Following this, he was discharged on oral nitrofurantoin prophylaxis and they were asked for regular follow-up. The child presented with a breakthrough UTI again at 1.5 months of age. So he had to be readmitted. He was treated with IV antibiotics. So my question would be to Dr. Sanjukta ma'am now that other than treating the urinary tract infections, what else needs to be done to this child who had a very bad bladder, has been operated and now presenting with a urinary tract infection?
So this child had already got the infection. So first of all, treating the urinary tract infection is very important. And to confirm that the UTI has completely cleared from a sterile urine. If not culture, we don't need to do a repeat culture, but urine RD can help, a routine examination. Following that, the child is already on nitrofurantoin prophylaxis. So we can see the antibiotic sensitivity pattern of the infecting organism, and we can see if there is any antibiotic which is sensitive among the prophylactic antibiotics which is sensitive against a specific organism, and change to that prophylactic antibiotic. Also, we need to take care of other factors like the child, if there is any underlying constipation present, so we need to treat that. We need to have a proper fluid management and check the electrolytes and follow up the renal functions for this child. And also we have to plan a DMSA scan for this child to see if there is any chronic damage but that has, to the kidneys, but that has to be done after at least 2 to 3 months. Cannot be done in acute phase. So these are the things we need to do after this for this child. And regarding the bladder tract, bladder management is very important for children with PUV. We need a lifelong follow-up for these kind of children. For that, we can think of, because we have already seen in the MCOG that the child is having a trabeculated bladder valve with multiple diverticulas. We can think of starting the child on oxybutynin. Because and also first of all we have to ask the child also how is the urinary stream and how is the it's very much very difficult to make a bladder diary. So at least about the stream the mother can tell us about, and whether there is any feature of straining and how is the frequency of urination. All these things, this can give us an idea. Also we have to refer this child to the pediatric surgeon for repeat check cystoscopy may be needed for any residual valve present. So you want to add something?
Who should the patient continue the follow-up with? Nephrologist or the both? We have to now walk the road together. It cannot be you walk and call me sometime. We have to walk together. Second is, in a patient of posterior urethral valve, we have not understood the disease completely. There are more things to learn yet. But as on today, whatever we know about the disease, our aim of treatment are perhaps 3. One is, we have to keep the patient out of infection. Second, we have to make sure that the patient stores urine under low pressure. And the third is, we have to make sure that the patient evacuates the bladder under low pressure. For that, whatever pharmaceutical agent needs to be done, needs to be given. For that, whatever repeat surgery or collateral surgeries, those need to be done, has to be done. So these are the paraphernalia which go on with posterior and valve patients. And of course, we'll have to keep looking at the renal function. That will be done by the nephrologist. And whatever medicine or measures that need to be taken will be taken by the nephrologist. Nephrologist will advise the urologist will comply with it, and urologist will suggest to the nephrologist if they can do something.
Thank you, sir and ma'am. So, for this child, mother was asked about symptoms of straining if she had noticed it, about the stream of urine of the child. The child was put on oral laxatives, and the surgical opinion was taken. And a bladder neck incision was done as per the opinions of the pediatric surgeons during that time, and after treating the urinary tract infection. And antibiotic prophylaxis was shifted from nitrofurantine to chlorprimoxazole. So I would like to again ask Dr. Basu sir that what is the indication of bladder neck incision? How does it help, and what further bladder management can be done?
See, initially we do not plan bladder neck incision unless the patient continues to have problems in the way of high pressure storage and high pressure evacuation and multiple infection. We initially try with Propan, which will relax the dead tissue, and we also try alpha blockers, depending upon whatever is the symptoms. And when the patient is more than 6 months old, we go ahead and do a urodynamic study. And if the dead tissue function is abnormal or the sphincter function is abnormal, we give medication accordingly. We can continue with the medication for some time, and if that medication is not giving us good result, we go ahead and do bladder neck incision. And the bladder neck incision is now an established method for treatment of bladder outlet obstruction, because we are worried about the overactivity of the rhabdosphincter, which we call rhabdosphincter spasm. For that, we did neck incision on the bladder neck at 4 and 8 o'clock position, and we cut right down after the as we do in the prostate operation, and we defunctionize the rhabdosphincter to get rid of bladder outlet. Rhabdosphincter problem. It is a procedure which is not agreed by everybody.
Thank you, sir. So, for the index patient, apart from the bladder neck incision, after this, since he was too small to plan a urodynamic study or a uroflowmetry, we started him on oral medications for bladder management. He was started on oxybutynin and an alpha blocker. So after this, this was when he was 1.5 months old, and presently he is 2 years. So we will have a timeline now regarding his course following this and how he progressed, what were the difficulties that were faced during this course. So we have already discussed that at 1.5 months of age, he had a breakthrough UTI on prophylactic antibiotics, bladder neck incision was done. He was started on bladder medications. We can see the dose that was given, and he was discharged on separate prophylaxis. A DTPA scan was planned after this, and at around 3 months of age, a DTPA scan was done. It showed the presence of hydronephrosis in right and left side of around 8 and 8.5 millimeter, and there was a delayed washout of dye in the right side. Left side did not show any obstructive pattern. And after this, when he was around 7 months of age, a UTS was planned. Meanwhile, when he would come for the follow-up visits, mother would always complain that he had problems of straining. The stream of urine was also not that good. So, if you see at the UTS study that was done at 7 months of age, the complaints were of interrupted stream and straining. These were the findings that we saw in his urodynamic study, and it gave the impression that the bladder capacity was very small, however with normal compliance, query overactivity and high detrusor pressure. dynamic outflow tract obstruction, query detrusor sphincter dyssynergia, query anatomical outflow tract obstruction. We can see the medications he were on. So I would like to ask Dr. Basu sir that at this stage, what should be done next?
See, if there is detrusor hyperfunction in a small bladder, we have to increase the pharmaceuticals so that the bladder relaxes in between. And for the outlet dynamic obstruction, we have to do a cystoscopy. And there is a trend now for treating such patients is to insert an oversized catheter for certain duration of time so that the dynamic obstruction to the outlet is neutralized. And it often happens if you have a uroflowmetry chart, if you put in an oversized catheter for some time, say for 10 or 15 days, and then take it out, the uroflowmetry curve becomes normal. So we do a repeat cystoscopy. We will look for any residual valve or bladder neck shelving. If it is there, we do again bladder neck incision. Put in an oversized catheter, keep it for 15 days, take it out. That may take care of the problem. Since these are the patients for whom I say that we do not understand posterior valve disease complex completely yet. We do a cystoscopy, find there is no valve, give the patient not the way we want the patient or expect.
Thank you, sir. So for this child, due to the high detrusor pressure, the dose of oxybutyrate was increased and a check cystoscopy was planned to remove any residual valve. So during this check cystoscopy and repeat valve calculation, and associated circumcision was also done. It was not done previously, and the dose of oxybutyrate was increased.
The child at 1.5 month had a bladder neck incision done. So obviously he had a check cystoscopy already done at 1.5 months. And if we had not found the residual valves at 1.5 months, I would be surprised somebody picked it up at 10 months. I mean, to my mind, it's not very clear. It can happen, of course. Small kids, small valves, or maybe you're looking for the bladder neck and inside the bladder neck and you don't pay attention to the residual valves. But it should not.
We have found residual valve even in the fourth time when you mean that not you personally.
I'm going to sink into the ground. This is, I'm just trying to figure out why we keep scoping a child. We sometimes would do that if, for example, we think that things have been missed or there's a stricture that could be developing. All of that we've seen, right?
Yeah, you're right, stricture.
Yeah,
that's also another
definitely. There's no question. I mean, we all have seen strictures happening. So, outflow tract obstruction can come from a lot of things. After all, we are putting in instruments. Some of these babies are very small, and sometimes even in good centers.
So we have found the stricture after like a third of and I think there is a correlation like number of scope and the chances of stricture can.
I'm not aware, but there are people who have actually shifted from fulguration, electric fulguration to lasers, the usage of cold knives because they find more structures. We somehow continue. I don't know. I don't have experience, so I cannot say, but these are issues that people have raised and people have moved to cold knife for PUV. We've consistently been using cutting current and fingers crossed we haven't faced too many issues. But these are things that are real. They happen.
But we do find patients coming with already having had at least 2 to 3 evaluations.
No, there are issues. For example, there can be equipment issues. For example, the scope that you're using, you may not be able to see. I've seen that a patient came to me who had undergone fulguration in a very reputable place and a very reputable surgeon. He had equipment issues. I've seen a complete shut-off of the urethra because of leakage of electricity. Again, another surgeon. These these things happen. That's why we have complications. So, but it would be, what I'm trying to figure out is, somebody has already done the scope, so check-scopy at 1.5 months, I would label that as check-scopy. You incise the valve and you go on.
Suchi, just one comment regarding your antibiotic prophylaxis which you gave in the first month itself. Is saying you chose nitrofurantoin. That's one drug that you should not be giving in the first 3 months. Right? At least cephalexin would have been a better choice. Avoid sulfur, avoid nitrofurantoin in the first 6 months. Right? Severe GI toxicity and area do not tolerate
very difficult to give
that is very bad in itself. Children do not. We should have been on cephalexin. Then later you shifted out.
How did you
I have one point to make. I have one point to make. I have one point to make. That is, when we get patient previously diagnosed prostatal, we prefer to put in a catheter and treat the diuretic phase. While we have the catheter in, the urethra may initially take. Can we carry on?
Yes, session question to run right after the
Right. Done.
There is no end to this dialogue.
For this. Yes, so for this child, again at 11 months of age, a repeat urodynamic study was done. Though the stream of his urine was better after the modifications of after modifications of his bladder medications and the repeat sex cystoscopy, mother complained of persistent straining while he would pass urine. So at 11 months, a repeat urodynamic study was done. And the impression was that on propan, it revealed a large capacity bladder with no overactivity and normal compliance. There was weak detrusal contractility with poor flow rate and queried with dynamic outflow tract obstruction, query dysfunctional voiding. So I would like to ask Sanjukta ma'am that what was wrong and how could we proceed next?
Like in the previous UDS, we have seen the child having small capacity bladder overactivity. So the detrusor was overactive. Now we have added propan and given in such an amount that the overactivity has suppressed, but the child is having a lazy bladder. So or unactive bladder. So here, if we take off that propan, the overactivity will come back. So we cannot do that. What we can do is to reduce the dose of propan. And along with that, we can add one CIC if there is significant amount of pre-intermittent catheterization, if there is significant amount of post-mortem residual urine present in the bladder.
Was the UDS done with while on the sacrifice we stopped at
Ma'am, he was actually during the first UDS, they had tried to do the urodynamic study after stopping propan for 2 weeks. But it was written in the reporting that the catheter came out while they were doing the study. It could not be done due to severe overactivity. So that time they had again restarted with propan and done the UDS. In this second urodynamic study, it was done on propan and hence they have reported accordingly. So for our patient, the dose of propan was reduced for the child and alpha blocker was continued. Also a repeat MCUG was done at this time and the MCUG revealed that there was no posterior valve now, but the bladder shape was persistently irregular and there was associated diverticulum. Sorry. So, meanwhile, due to non-availability, Welcome was stopped and he was started on Hydrain. And also, the child complained of severe straining during passing urine. Without repeating urodynamic study, propan was again increased And then he had, mother was also explained the procedure of clean intermittent catheterization, was advised to do so. She was explained the procedure and the importance of maintaining a bladder diary, but it was very difficult for her to do that at that point because the child was very young. He during this time had a breakthrough UTI. Also, after treating this episode of urinary tract infection, a MR urogram was done. And the MR urogram revealed that there was persisting bilateral hydronephrosis, mild increase in hydronephrosis with anterior posterior diameter of 12 mm in right side and 14 mm on left side with thickened bladder wall, claviculated bladder wall and significant post-void residue. So, the tropan was stopped and at the same time, after stopping tropan, a urodynamic study was again done. And this was the urodynamic study that was done at 1 year, 11 months of age. The complaint was primarily of severe straining while asked to pass urine. Tropan had already been stopped. The symptom did not improve completely. However, the urodynamic study revealed that it was a normal capacity bladder with severe overactivity and leak, mildly reduced compliance with no evidence of outflow tract obstruction and complete emptying of bladder. So, what should be done next? And if the bladder management had been optimum till now? I would like to kindly ask sir.
I have already admitted we do not understand this completely. But the question is that we have to have no solution. We will have to continue with the disease and see whether the renal function is getting deteriorated or not. If the renal function is going down, we have to make sure that the CIC is done properly. If the CIC is done properly, we will try a continuous whiteboard dilatation of the urethra for 15 days and see whether we can get rid of the rhabdosphincter spasm. Maybe the rhabdosphincter spasm which is creating only problem.
Thank you, sir. So, for our child, tropan was continued on low dose because we decided that tropan cannot be completely stopped because he was having worsening of his straining complaints, and bladder diary that was done by mother also showed increased frequency with with small capacity bladder. Since he was passing urine that was much smaller than his expected bladder capacity. So, we restarted him on tropan. And it was planned that tropan will be continued on a very minimal dose. Mother was explained the process of clean intermittent catheterization. In fact, he was admitted for a day to explain the procedure properly. And every 3 hourly, mother was explained to do the same, along with overnight continuous drainage. And a mother is presently using a reusable rubber catheter because it has to be used regularly and there will be financial constraints. So she is using that for the CIC procedure. And measures were taken so that his bowel movement would be regular. Laxatives were added, and we had planned to watch him regularly to look for evidence of hypertension if he was developing hypertension, proteinuria and progression of CKD by checking his urea and creatinine, and a regular bladder diary with ultrasound KUB every 3 to 6 monthly was planned. So this is our child presently who is around 2 years of age, and symptoms of straining sometimes do persist, but the patient is continuing on the bladder management as planned.
Add protein creatine ratio this study investigation.
Yes, sir. Protein creatine ratio in urine. So this is the end of our second case.
In between, no UST.
Yes, sir. Ultrasound was done. When he had this episode of breakthrough UTI, ultrasound was repeated. Also, an MR urogram was done. Ultrasound revealed that the hydronephrosis was increasing. Initially, it was only 8.9 and 8 mm.
Tell you more about the kidney.
Post-void residue.
No, cortex and medulla, all those things.
Yes, sir.
Whether the kidney is increasing in length according to the child's age or not, all those things can be done by
yes, sir. So, ultrasounds have yet not reported any abnormality in echogenicity or corticomedullary differentiation. but in the bladder
What
we
is the
all.
blood pressure now?
So blood pressure, as per the blood pressure records in his OPD visits, are still now maintained between 15th to 90th centile. Also, I forgot to mention, but anthropometry was also monitored, and his height and weight gain is also age appropriate. Mother is very compliant, and she has been following up.
And the hemoglobin? Not only immediate reaction, but
I am not sure, but I think his hemoglobin was checked.
all those things should be taken together.
Yeah, that's a good question. I think
Any role of
botulinum toxin is something that needs to be explored.
Probably बोलने का होगा कि
Hey, Nephro, Sushmita ji बोलते हैं you people have said everything.
No, that is what exactly I said. Don't stretch the session on PUV after
we
this.
don't have anything to say.
Exactly. I kept telling you,
Hey, I'm bullying you.
Thank you.
I was busy.
Thank you so much.